pleasant good morning, all, and welcome to our second annual PEDS Week lecture series. Our topic or our theme for this year is our commitment, caring for kids. And today we have three dynamic speakers that are subspecialists in the pediatric field. Allow me to welcome our first speaker, who is none other than Dr. Nicole Jones. A little bit of background information about Dr. Jones. Dr. Jones is homegrown. She's right here from Nassau, Bahamas. But currently, she is the Assistant Professor of Pediatrics at University of Alabama, Division of Pediatric Emergency Medicine. She is double boarded in general pediatrics and pediatric emergency medicine. Her career focuses on providing clinical care and medical education to fellows, residents, and students. She has received multiple resident teaching awards. She works clinically as a pediatric emergency medicine nocturnist in the Children's of Alabama Emergency Department at the only freestanding children's hospital in the state of Alabama. Currently, she serves as the medical director of the American Heart Association PALS course at Children's of Alabama Pediatric Hospital. So please help me welcome Dr. Nicole Jones as she speaks on her topic, pediatric toxic injections.
Good morning, everyone. I am Nicole Jones, and I'm a pediatric emergency medicine physician at UAB. And like Dr. Chisholm said, I am born and grew up in Nassau, and I am truly honored to be able to speak with you guys today on my topic, which is pediatric toxic ingestions. So briefly, we'll do a little introduction, and then I'll speak on some of the epidemiology. And then I'm going to go through the acute management of any child that presents with a toxic exposure. We're then going to briefly go through 5 of the top most toxic exposures that we see in kids. And then finally, I'm going to speak on cannabis exposure, in particular, cannabis edibles, which has really become a problem for us in the pediatric emergency department. Okay, so in introduction, injury is one of the leading causes of pediatric morbidity and mortality. It is the #1 cause of pediatric deaths that we see in the USA. Toxic exposures and poisoning are an important mechanism of injury. In 2019, the Center for Disease Control showed an increase in poison death rates of 50% in Hispanic children and 37% in Black children in the US. Toxic exposures are one of the more common medical emergencies involving young children, but they also account for a significant amount of adolescent emergency department visits. So who, why, and what are they getting into? So in 2022, there were over 2 million reported poison exposures to the US National Poison Center. And kids less than 20 make up more than half of all reported poison exposures. More specifically, little kids, so less than 5 years old, make up 40% of all reported poison exposures in the country. And then it typically has a bimodal distribution. So you see this large peak of exposures in kids less than 6, and then you see a smaller peak in our adolescents, so 13 to 19 years old, with really more of a concentration around the 15 to 17-year-olds. So the reason for this bimodal distribution is just developmentally. So children that are less than 6, your toddlers are picking up things, putting them in their mouth. And so by and large, the exposures that we see in this age group are unintentional exposures. And even though they carry the largest amount of exposures, they actually have a fairly low fatality rate, which makes sense because it's not intentional. They're just picking up something that they see on the floor and putting it in their mouth. Contrasting that to our older kids, so 13 to 19-year-olds, they have a lower exposure rate, but a higher fatality rate because typically these are intentional ingestions. So whether it be self-harm attempts or attempts to get high. So the top 10 exposures for children less than the age of 6 um, goes along again with the fact that they're just kind of scavenging, picking up whatever they see and putting it in their mouth. So cosmetics and personal care products had the highest percentage, cleaning and household products, followed by analgesics, diet supplements, foreign body and toys, with our big concern always being button batteries, vitamin ingestions, antihistamines, and others. So we can break down overall exposures into the particular exposures that were more fatal in kids. And we can see a lot of crossover between the younger children and the older children. So in the less than 6, the top exposures that were fatal were analgesics, fumes, gases, vapors, batteries, again, button batteries, stimulants and street drugs, hydrocarbons, and then the cardiovascular drugs. In our older children, analgesics again was number 1, followed by antidepressants, antihistamines, cardiovascular drugs, unknown substances, and then stimulant and street drugs. So in pediatrics, where most of us are familiar with the phrase "one pill can kill," this was coined in the 1990s in an article that was published that looked at common medications that 1 to 2 typical adult doses can be fatal in a small child, so in a toddler, a 10-kilogram kid. And the list includes calcium channel blockers, beta blockers, opioids, sulfonylureas, salicylates, tricyclics, camphor, chloroquine, and theophylline. So the acute management of the child that presents critically ill with a known or suspected ingestion. I want to highlight that we always say nothing beats a good history. So this is going to be a focused history. If you have a known ingestion, then you want to find out from the family, what is this medicine? What is the strength? The formulation of the medication? Is it extended release? Is it enteric coated? Is it an immediate release? You want to find out how much was ingested, if possible, and the specific time of ingestion. Sometimes this requires some detective work, having the families, if they're able to count how many pills they've taken so they know how many are left over. It can take a little figuring out. Sometimes families will come in and they have the pills, but they don't actually know the name of the medicine. There are multiple apps and sites that you can find that can help with pill identification that can be very helpful in those situations. So, and then for a child that comes in with an unknown but suspected ingestion, you want to find out from the family what all medications are in the house. It is not uncommon that we will hear, "Oh no, everything that we have is locked away." And I always say to families, no, I need to know everything that's in the house because none of us are infallible. Anybody can drop a pill that a small child can get into. And then in addition to that, you want to know, have they been around anyone else? We think about grandparents who are commonly on some of the more dangerous medications, including blood pressure medications or medications for diabetes. So you really want to know any possible exposures. If it's an older child in particular, you want to find out, is there a mental health history? Is there a history of depression? Are there any prior suicide attempts? All of that can be helpful in figuring out what you're dealing with and how you're going to manage this child. And then, of course, you're going to get your general history, your past medical history, allergies, and then any specific details leading up to presentation. Okay. So the acute management of the kid that presents with concern for a toxic ingestion, it's always going to come back to your ABCs. So this is where your pediatric advanced life support, your basic PAL skills are going to come into play. And it doesn't matter what the ingestion is. This is always going to be the base of what you're going to do. So first A is your airway. The most likely cause of death in pediatric poisoning is going to be respiratory failure, progressing to respiratory arrest. So you want to make sure that your patient has a patent airway. If your patient comes in and they're little and they're crying vigorously or they're talking to you, airway's probably okay. But you want to watch this closely because it certainly can change. And depending on the medication that they may have gotten into, you may not be at peak effect. And so they may progress to lose their airway. So this is, really, really close monitoring. If you need to, you can use airway adjuncts in your patient that's still awake, but just maybe having some upper airway obstruction. You can consider a nasal airway. If your patient is obtunded and you think you're going to need to bag them, or you're having difficulty bagging them, you can consider an oral airway. Remember, that cannot be used in a patient that's awake and alert because you can trigger the gag reflex. And sometimes you may end up needing to take control of the airway and intubating the patient, depending on mental status, or if you're worried about aspiration. So next is breathing. You want to pay close attention to the rate. So are they tachypnic? Are they breathing really quickly? And the quality of the breathing. Is it deep breaths? Is it shallow breaths? You want to put these kids on a continuous pulse ox if possible. And if you have a CO2 detector, then that can be beneficial as well. So paying attention to the breathing is kind of twofold. One, you need to know that they're breathing adequately, and if not, then you need to intervene. But two, it can also give you information about what they could have possibly gotten into with certain medications leading to certain different breathing patterns. And again, if you need to provide supplemental oxygen, you go ahead and do that. If they do not have adequate respiratory effort, then you may need to bag, mask, ventilate your patient. So C is circulation. We always say vitals are vital. So you're paying really close attention to the heart rate, the blood pressure, and then their overall perfusion. You want to establish IV access as soon as possible. If you're unable to establish IV access, then you can place an IO. Depending on their perfusion and looking at their blood pressure, if they have poor perfusion or a lower blood pressure, you want to consider giving this patient an isotonic fluid bolus. And then this is an opportunity to also get your labs. So in any ingestion, whether it's a known ingestion or a suspected and you're not sure, there are certain drugs that you always want to test for if possible. If you can get a Tylenol level on these kids, a salicylate level, that's really important because a lot of times you have a co-ingestion, and these are things that can be lethal, and we actually have the ability to intervene on if we find out the information early enough in the course of their presentation. Ethanol, alcohol, especially in younger kids, that can be important. And then general electrolytes, liver function. Oh, and a glucose. That is something that you should do as soon as possible. Get a quick D-stick. That is something that is so easy for us to fix. And if we don't fix it, it can have significant, negative outcomes. So always check a glucose on these kids as well. And then lastly, you want to have them on the cardiac monitor, and you want to get an EKG to check for any arrhythmias. So disability, the D, I like to think of D for disability and D for dextrose. That way you always remember, check a sugar, check a sugar. So you're going to assess the mental status of your patient. You can use whatever scale you're comfortable with. I like the Glasgow Coma scale, which is represented here on the right. You can use the AVPU scale, whatever works for you. But you're going to monitor closely their neurologic status. Check your glucose. You can fix that if you need to. And then I included decontamination in here. And some of this has been controversial. I think most of us are familiar with the use of charcoal, activated charcoal. It can absorb a lot of toxins. And so it can be very useful, in particular, if a kid presents within the 1 hour of the time of ingestion. Keep in mind, it does not work with every medication. So you want to make sure it's a medicine that's amenable to charcoal before giving it. And you also want to make sure that your patient is awake and alert, because risk of aspiration is very real and can be, charcoal is a pretty nasty aspiration if it gets into the lungs. And so you can only use this in a patient that's awake and alert. Um, Whole bowel irrigation is used even less commonly. Oftentimes this requires putting down a nasogastric tube, and then you are essentially flushing the bowel with polyethylene glycol and fluids. Studies really haven't borne out that this has had a positive impact long term in the outcome of these kids. So it's very rarely used. And then gastric lavage and syrup of Ipecac are both kind of a nose. Those are no longer in play and haven't been found to be very beneficial. So your toxidromes, when a kid comes in with an undifferentiated ingestion, a lot of times you're playing detective, and toxidromes can be very, very helpful in this regard. So what is a toxidrome? A toxidrome is a constellation of findings that are specific and unique for a type of poison. So there are 5 main toxidromes. So the first one I'm going to talk about are the anticholinergics. So you can see this toxidrome with antihistamines. Some of the tricyclic antidepressants can have anticholinergic effects. Atropine is a pure anticholinergic. And I like this mnemonic to help me remember the symptoms. So hot as a hare, dry as a bone, blind as a bat, red as a beet, and mad as a hatter. Hot as a hare because oftentimes they have temperature elevation, dry as a bone, dry mouth, they're not urinating, dry eyes. Blind as a bat because they get pupillary dilation. Red as a beet because oftentimes you have flushing, and then mad as a hatter because you can have a lot of agitation. So the opposite of the anticholinergics are the cholinergics. And so this is common in a lot of pesticides. So kids kind of get out into the garden and can get exposed to this. Physostigmine is another cholinergic. And for this one, I use the mnemonic sludge. So salivation, lacrimation, urination, defecation, GI upset and emesis, and then the 3 B's. Bradycardia, so you're dropping your heart rate, bronchospasm, and bronchorrhea. Lots and lots of fluid in the lungs. So the next toxidrome is the sympathomimetics. These are your adrenergics, your stimulants, a lot of the ADHD medications, and then a lot of illicit drugs, cocaine, methamphetamine. And I think of the sympathomimetics as the drugs that are revving everything up. And so they're hot, they're sweating, the heart rate is racing, they're hypertensive, they're breathing really quickly. And kind of in contrast to that are your sedative hypnotics. So your benzodiazepines, some antihistamines like diphenhydramine can have sedative properties. And these are very calming, they're slowing you down, they can decrease respiratory effort, kind of the opposite of your stimulants. And then the last toxidrome are the opioids. So these are common analgesics, pain medications, pharmaceutical and illicit drugs. And they have a very classic toxidrome, typically a depressed neurologic status, pinpoint pupils, respiratory depression, everything is kind of lowered, hypotension, hypothermia, hyporeflexia. And so these toxidromes can be really useful when you're trying to figure out what substance a kid may have gotten into. Okay, so one pill can kill. I'm going to briefly go over some of the most common fatal exposures that we see in the pediatric population. So calcium channel blockers, these are bad. These are probably the ingestion that I worry about the most when it comes into the emergency department. Unfortunately, I haven't seen it very often. But calcium channel blockers are fairly common medications used to treat various cardiovascular diseases. So hypertension, SVT, supraventricular tachycardia, migraines. Some names you may hear are verapamil, amlodipine, nicardipine. It is a very important source of drug-induced mortality. We don't see a lot of kids come in with calcium channel blockers, but out of those that do come in, the fatality rate is pretty high. These ingestions are tough. So this is one of the classic one pill can kill medications. And kind of a simplified mechanism of toxicity, calcium channel blocker, it is blocking the influx of calcium into the cells. Particularly, it acts on vascular smooth muscle in the heart and in the periphery. So when you get that peripheral vasculature dilation, you're dropping your blood pressure. And then it also acts directly on the heart. It slows conduction and it reduces cardiac contractility. So you're losing your heart squeeze. Oh, another really important distinguishing factor with calcium channel blockers is that they inhibit insulin secretion in the pancreas. And so when you're trying to distinguish between what medication did this kid get into, with calcium channel blockers, they are going to have an elevated blood glucose because insulin is not being secreted. And so that can be really important in helping you figure out what's going on. So your classic signs and symptoms, kind of the classic findings with your calcium channel blockers are low blood pressure, low heart rate, and then the hyperglycemia. So how do you manage these kids? Again, I just want to stress that for any kid that's coming in that's critically ill, any kid coming in with a toxic ingestion, you are always going to cover your ABCs first. So, but specifically for a calcium channel overdose, you need to give these kids calcium. Calcium gluconate is typically our go-to because it's safe. It can be given through the peripheral IV. You can repeat it as needed. It is very effective at reversing the cardiac contractility depression. So it's giving you back your heart squeeze. Unfortunately, it does not do anything for your peripheral vasodilation. And so you oftentimes will need other things to help augment your blood pressure. You can consider epi as a pressor. Glucagon has been found to be beneficial. You can consider hyperemia and euglycemia. If you're going to do this, ideally you want to get pharmacy involved because you are giving super high doses of insulin, up to 10 times the amount that you would typically give in a child that's coming in DKA. And so it really needs to be fine-tuned so that you're not bottoming out these kids' sugar. And then you can consider decontamination for sure, especially if they're presenting within 1 to 2 hours of time of ingestion. So moving on to your beta blockers, another cardiovascular, a common cardiovascular medication. Again, this is lots of grandparents around. They can be on these medications. They're used to treat high blood pressure, arrhythmias, heart failure patients, migraine headaches, glaucoma. And then there are many different examples. These are your ALOL medicines, so labetalol, propranolol, atenolol, sotalol. And their mechanism of toxicity, they are antagonists at the beta receptors. And so this results in a decrease in your adrenergic transmitters. So subsequently, you get lower heart rate, lower heart contractility. And then at the beta 2 receptors, they are responsible for decreasing glycogenolysis. So you can't break down your glycogen to get sugar. They decrease gluconeogenesis, so your body's not able to just make sugar. And then it reduces lipolysis, and so you can't break down fat in order to get sugar either. And so that results in the opposite of what we see with the calcium channel blockers. And these kids come in with a bottomed out glucose. So classic signs and symptoms for beta toxicity, again, hypotension, bradycardia. So that's not going to help you differentiate between a calcium channel blocker and a beta blocker. The big difference is these kids are going to have a low sugar. And then a few of the beta blockers are very lipophilic, and so they can easily cross the blood-brain barrier. And for those particular substances, you can see a lot of CNS, central nervous system effects as well. So you can have seizures, you can have coma, you can have respiratory arrest. So acute management for the beta blocker toxicity. For your bradycardia, you can use atropine. Sometimes you have to cardiac pace these kiddos. For bronchospasm, you can use nebulized bronchodilators like albuterol, the same as you would use in your asthma that's coming in with bronchospasm. And then specific drugs are glucagon. Keep in mind that glucagon is releasing glucose from glycogen stores. So in really small kids that don't have large glycogen storage, it may not be as effective, but it can definitely buy you some time while you're placing your IV and being able to start them on a dextrose-containing fluid. Also, again, your pressors, epinephrine, if you need it for blood pressure, and sodium bicarb has also been found to be useful. Okay, moving on to our opioids. These are common analgesics, act on opiate receptors in the central nervous system and peripheral nervous system to block pain signal transmission. They are popular both from a pharmaceutical standpoint and also a popular street drug. You have the naturally occurring opioids like morphine, heroin, codeine. We're familiar with some of those names. And then you have the synthetic opioids, fentanyl, meperidine, and methadone and buprenorphine. So I want to quickly just touch on the methadone and the buprenorphine because those are emerging problems that we're seeing in the pediatric population. So as we develop new ways to treat substance use disorders, these opioid partial agonists have become more and more popular. However, they are very, very long acting. And so we're seeing more and more children coming into the emergency departments with overdoses on these medications that can be pretty harmful. So mechanism of toxicity for your opioids, they are stimulating the mu receptors in the central nervous system. And so they can cause a central apnea. So essentially your brain is not telling your respiratory system that it needs to breathe. And so you get respiratory depression in a very dose-dependent fashion. You can also have bradycardia, so a lower heart rate associated with it as well. So in mild to moderate overdose, kids come in, they're out of it, they're lethargic. Classic opioid finding is the pinpoint pupils. Often they have decreased blood pressure, decreased heart rate, and diminished bowel sounds. It acts to kind of slow down the gut as well. In higher doses, you can have frank coma, respiratory depression that progresses to apnea, and you can also see sudden death. So in opioid overdose, acute management, naloxone is really the game changer. So this is an opioid antagonist that will displace the opioids, and you will have within seconds reversal of symptoms. You can give this in almost any way you can think of. You can give it intranasally, you can nebulize it, you can give it IM, IO, IV. It's very versatile in that way. And the dose for children is going to be 0.1 milligrams per kilogram IV, or whichever method that you have access to. And you can give it every 2 to 3 minutes as needed. What's really important to note with Narcan is it has a fairly short half-life in comparison to a lot of the opioid drugs that you're going to be using it to treat. And so what that means is you can give them a dose of Narcan, they wake up, they're alert, they're talking to you, they're breathing, and then you leave them and go about your business, and you come back and they're not breathing again and they're out of it because your Narcan has worn off and their medication is still on board. So it's not uncommon that we have to start these kids on a Narcan drip and IV infusion for the longer acting opioids. So I don't think that this is happening back home as yet, but in the US now, there's been a huge public health harm reduction initiative where you can get Narcan over the counter. They're encouraging college kids to just have it on them. Because we've seen so many fatalities associated with opioid overdose, in particular fentanyl overdose. And so you can just get this over the counter and keep it on you. And it saves lives. Okay, so moving on to acetaminophen. This is a common pain medication and also an anti-fever medication. It can be found in so many over-the-counter and prescription products. So overdose on acetaminophen or Tylenol is the most common cause of liver failure in the United States. And potentially toxic dosing occurs at greater than 150 milligrams per kilogram in children and greater than 6 to 7 grams in adults. And so the mechanism of toxicity, normally if you take acetaminophen or Tylenol at a regular dose, the liver is able to handle it. Tylenol is broken down into a toxic substance called NAPQ. And in the liver, glutathione helps to convert NAPQ into non-toxic products. What happens with a Tylenol overdose, you use up all of your glutathione. The NAPQ now is able to build up in your liver, and it is extremely hepatotoxic. And so that's what leads to the liver damage. So acetaminophen toxicity kind of takes place in 4 stages. And this is where it gets dangerous in a child that doesn't disclose that they took the acetaminophen, because they can initially have a little bit of nausea, a little bit of vomiting, maybe some tummy pain, but then they have a period where they're actually pretty asymptomatic. And then at 1 to 3 days, that's when the liver damage starts to happen. If you do testing at this time, you're going to see elevation in their liver function test. They may start to complain of right upper quadrant pain. And then over 3 to 5 days is when they become extremely sick with just frank liver failure. And oftentimes that can be fatal. The good news about acetaminophen toxicity is that if we find out that a child has had a significant acetaminophen toxicity, we have an antidote that can prevent liver failure if it is started within 8 hours from the time of ingestion. And so that's one of the reasons that any kid that comes in with suspected ingestion, we get a Tylenol level on them, even if they swear up and down that there's no way they got into Tylenol, because on the small chance that they did, it can be fatal, and we have an opportunity to intervene if we find out soon enough. So this diagram on the right is called the Rumack-Matthew nomogram. And what you do when your patient comes in, you want to get a 4-hour acetaminophen level. So 4 hours from the time of the ingestion, and then you plot it out on this nomogram. If their level is greater than 150, some people will use 150 to 200, then you're going to go ahead and start them on the antidote, which is N-acetylcysteine or NAC. And again, really important to get this started soon, ideally within 8 hours of time of ingestion. Some studies have shown that you can still have benefit up to 24 hours of ingestion. Okay. So finally, on to the salicylates. So this is your so the salicylates. So widely used medication, common pain medication, anti-inflammatory medication. Aspirin is what everybody's most familiar with. It's found in many combination products. Interestingly to note that prior to the introduction of child-resistant containers, aspirin overdose was a leading cause of childhood accidental death. So this was a very successful public health initiative that was pushed by pediatricians. So oil of wintergreen in particular, which you can get over the counter, is extremely toxic for kids. 1 milliliter can have 1,400 milligrams of salicylate in it. And a toxic dose for kids can be 150 milligrams per kilogram. So in your 10-kilogram kid, 10 times 150 is 1,500. 1 milliliter can be enough for them to have a toxic dose. So salicylates act to stimulate the respiratory center in the brain. And so you get hyperventilation, which can lead to a respiratory alkalosis. And then it also can be poisonous to your mitochondria. And so they're not working effectively, and you get a metabolic acidosis. So you get a mixed acidosis picture, which is kind of the classic finding in salicylates. So symptoms can include vomiting, a deep, quick breathing, ringing in the air is a classic finding, lethargy with more severe intoxication. You can have coma, seizures, cerebral pulmonary edema, and just frank cardiovascular collapse. The management of these patients, you want to obtain serial salicylate levels. You want to aggressively treat the metabolic acidosis with the use of sodium bicarb. And sodium bicarb, actually, you can kill two birds with one stone because it's also effective at alkalinizing the urine. And so you are able to increase your secretion of the salicylates. Okay. So finally, I wanted to talk about cannabis, in particular cannabis edibles, which has been a growing concern for us in the US. Um, We've been seeing increasing numbers of kids show up in the emergency department really sick, secondary to cannabis edible exposures. So many jurisdictions, kind of worldwide, the US, Canada, several European nations have either legalized cannabis for recreational use or are in the contemplation stages about whether or not they want to consider legalizing cannabis for recreational use. So over the last decade, in the US in particular, cannabis has also become more potent. So there are higher concentrations of the psychoactive ingredient, which is the delta-9 THC. So the increased availability and marketing, accompanied by the increased potency, has led to increased numbers and severity of kids presenting with cannabis edible exposures. So edible products are the primary driver of the increased unintentional toxic exposures in young kids. You can see from the pictures that these are examples of some of the edible products, and they look like regular snacks. And so you can see how a small child would eat a bag of that. A recent study in 2023 that looked at the US national poison system found an increase of 1,375% in edible cannabis exposures between 2017 and 2021 in children less than 6 years old. In addition to that, there's been a notable increase in ICU and non-ICU pediatric admissions, and a decrease in the number of kids with a THC exposure that are able to just go home and be discharged from the emergency department. So the severity of the toxicity is directly related to the dose of THC ingested. And so another recent study found that a dose of 1.7 milligrams per kilogram can predict severe and prolonged toxicity. So if we take, for example, this bag of Jolly Rancher THC gummies, the bag has 600 milligrams. So for a 4-year-old that weighs 20 kilograms, if he ate just 1/8 of the package, he would be more than double the toxic dose. So, what are your classic symptoms? The most common symptoms that have been found, and this goes along with my personal experience as well, is central nervous system depression. So, they're coming in, they're lethargic, they're ataxic, unsteady gait, they're agitated, they're confused, they're dizzy. On occasion, kids are presenting with seizures. Cardiovascularly, kind of all over the place. Sometimes tachycardia, sometimes bradycardia, more often low blood pressure, sometimes high blood pressure. You can have nausea, vomiting, abdominal pain, and then respiratory depression and hypoxia. So they're not breathing effectively and they're needing help. Again, your ABCs, can't forget those. And then supportive care measures. We don't have an antidote for this. So if they're not breathing well, supplemental oxygen, intubation if you need to. If they're really agitated, you can use benzodiazepines, your antiemetics for nausea and vomiting, and then just observation. Keeping in mind that when marijuana is smoked, the onset of action is within minutes, and it's out of your system pretty quickly as well, versus some of these edibles that can really have a prolonged course, especially if they ingested a high dosage. So harm reduction, what can we do? You know, prevention is better than cure. There are several public health initiatives in the US right now, just educating, well, one, ourselves, and also just the general public on the acute and chronic harm involved in cannabis edibles. As pediatricians, we can take the opportunity in your well child checks to find out from families, are there edibles in the home? And if so, encourage safe storage, in particular if there are children around. And then kind of on a larger scale, there are lots of advocacy initiatives looking at making the packaging less attractive so that they're not targeting children, and also limiting the total THC dosing per package. And some of these initiatives have been successful. I know in California, they've been able to ban some of those prior pictures that I showed you. Some of those snacks have been banned. The packaging has had to be changed, and they've been limiting the total THC to 10 milligrams per package. So take home points. Briefly, toxic exposures are responsible for significant morbidity in kids, and they typically present in a bimodal distribution. So your little kids where it's unintentional exposures, and then your older teenagers with intentional exposures. Acute management of any exposure should initially focus on ABCs, and always remember to check a glucose and strongly consider naloxone and Narcan. So much so that for anybody that's recently taken PALS, Pediatric Advanced Life Support, the 2020 update actually includes the use of Narcan for a kid that comes in that's obtunded. Remember that for many common medications, 1 or 2 adult doses can be fatal in a small child. 1 pill can kill. Toxic cannabis exposures are on the rise in places that have legalized recreational cannabis use, and routine anticipatory guidance for parents and increased public health educational initiatives are needed to help keep our children safe. Those are my references. So thank you for listening. Does anyone have any questions at all?
Thank you so much, Dr. Jones, for an awesome presentation and an excellent overview on pediatric toxic ingestions. We are running a bit behind time, but we will accommodate 1 or 2 questions if there are any questions from the audience or from persons joining us virtually. Any questions? Okay, we have a question. So the question was, can you talk about vaping? Have you seen that, and what are you guys doing about that in the pediatric emergency room?
Yeah, we actually have seen a lot of vaping. We've seen vaping with nicotine, kids coming in with just anxiety reactions a lot of the times. Nobody's been super sick from the nicotine exposures, but what has been a concern is little kids getting into the vaping products because the nicotine can be very toxic and it's very concentrated. And then we are seeing more vaping of the cannabis as well. And again, they can get higher doses. And so we are seeing toxicity related to the THC vaping as well. Yeah, definitely. Actually, there's more vaping now of THC than we're seeing just the smoking. And actually, recent studies have shown that there's far more vaping going on and nicotine exposure that way as opposed to smoking cigarettes in children. And that's another one where the marketing has been terrible with just bright colors and flavors, and they've really been targeting kids. And so there have been some initiatives to try and improve that as well.
Okay.
Any other questions?
Okay, we have another question. Okay. So the question basically is from cannabis exposure, have you had to intubate patients secondary to cannabis exposure? And I guess what percent of the patients you see with cannabis exposure gets admitted?
So, in the small kids, we're seeing it more and more. I personally have not intubated anyone with cannabis exposure, but some of my partners have. And if you look at like the recent literature, there are more and more cases of kids needing to be intubated. I had two recent cases. Kids that were about 4 years old. I didn't need to intubate them, but they definitely had like inadequate respiratory effort. I needed to do things to kind of stimulate them. Both of them were started on oxygen. Both of them came in very hypothermic, needing to be placed on the bear huggers to warm them up. So these kids are coming in pretty sick, especially the little ones.
Yeah. Okay, thank you for that information. We've had that similar experiences where these children are coming in completely obtunded and taking days to come around for a few of them. So thank you very much, Dr. Jones. And I am now going to introduce our next speaker. So our next speaker is going to be Dr. Kriso Katsufis, who is also a friend of mine. We did residency together. Her topic will be doing more with less, the long-term impact of nephron loss in childhood. But just a little bit of background in regards to Dr. Katsufis. Dr. Katsupis is a pediatric nephrologist and associate professor of clinical pediatrics at the University of Miami School of Medicine. She also serves as the medical director of the pediatric dialysis unit of Holt's Children's Hospital at Jackson Memorial Hospital. She received her undergraduate bachelor's degree in biology with a concentration in neurobiology from Northwestern University before matriculating to the University of Miami School of Medicine. Her doctorate of medicine was awarded in 2006. She completed residency training in pediatrics in 2009, followed by fellowship training in pediatric nephrology in 2012 at Holt's Children's Hospital. Currently, her clinical research is focused on congenital anomalies of the kidney and urinary tract as they relate to the developmental origins of adult disease. In addition, she is active in team science investigation, contributing to the study of kidney disease in children through multiple national and international consortia. Please help me welcome Dr. Katsufis.
Good morning, everyone, and thank you so much for this opportunity. I am thrilled. I really am. I'm so happy to be joining you all this morning and to share a little bit of my less sexy passion with you all. And that is really to be talking not about dialysis, not to be talking about dialysis or the most extreme forms of congenital anomalies or pediatric kidney disease, but rather to be sharing some of the insights we have on low nephron endowment children with fewer nephrons for varying reasons and their long-term impact. So many of us, all of us, in fact, spend time talking about things that would impact long-term health and tend to be harder to impact change. And this is going to fall into one of those areas. So our objectives for this morning are to recognize the origins and burden of low nephron endowment, to explore the short and long-term impact of hyperfiltration, and to specifically review and share the more recent literature regarding risk factors, outcomes, and management. And all of this really from a perspective of general pediatrics and how we can all improve long-term health into adulthood. So looking first at low nephron endowment. I'm going to share some pictures with you here. This is an autopsy study, in fact, from the chief of my division, Dr. Carolyn Abbott-Ball, and one of our renowned pediatric pathologists, Maria Rodriguez, who, in looking at autopsy studies, were able to share what you see. That dark purple ridge here is that nephrogenic zone where new nephrons are being formed at different stages of gestation. So what you see is at 9 weeks here, then again at 17 weeks gestation, and at 24 weeks. And we still see at that outer edge that purple, dark purple ridge, which is where new nephrons are being formed, not unlike the rings on a tree. So now we look further along gestation, 28 weeks, 32 weeks, and what you see at a year of life, postnatally, is we've lost that purple ridge. So that message here is that kidney growth after birth is related to hypertrophy, and you see how we don't see new dark purple filters, but what we see is an expansion of that interstitium versus the glomerulogenesis and the multiple dark purple nephron filters being formed in the previous slides. So what we understand better is that exponential nephrogenesis is occurring between 20 and 28 weeks of gestation, with cessation between 32 and 36 weeks. And why does it matter? Because if delivered preterm, autopsy evidence of nominal glomerulogenesis is only up to 40 days post-delivery. And in fact, those nephrons are really not normal, healthy nephrons. They are better than nothing, but they are not the healthy nephrons we get pre-delivery. So ultimately, what you're left with is a child with low nephron endowment compared to what their potential was. So nephron number actually, of course, like everything, exists on a bell curve. And if your natural endowment has you on the right side of this graph, and you are cheated with preterm birth by some of those nephrons, you may still fall into a very safe range of nephron number for lifelong use. However, if your natural endowment has you on the left side of this graph, and on top of that with preterm birth, you're cheated of further nephrons, it really could get you into a zone where you have relative oligonephronia, or fewer nephrons than what you'll need for lifelong health. So when we talk about the burden of disease of prematurity, in the US, we're talking about 10% of all US births, and globally, 15 million. Now, added onto that, I want to expand a little bit on congenital anomalies of the kidney and urinary tract to include anomalies of number, size, position, function, dilatation, all of these that you see here in the example photographs with agenesis, multicystic dysplastic, hypoplasia, reflux, or obstruction, their common denominator is that they have fewer functioning nephrons, very similar to preterm. So just looking at congenital anomalies, we're talking about 0.5% of all pregnancies and 3 to 6 per 1,000 live births. But they really do account for 20 to 30% of all neonatal anomalies. And then when we get out of this zone, we're looking at up to 60% of childhood chronic kidney disease and anywhere between 40 and 50% of children who end with dialysis or transplant. If we look specifically at hydronephrosis, it's obviously a very common finding affecting up to 5% of all fetuses during gestation. And while it may be easy, and even for me, to be somewhat dismissive of unilateral antenatal hydronephrosis, we do need to keep in mind that up to 15% are ultimately associated with reflux. And the incidence is rising. So right now, we're talking about 1 in 1,000 births having hydronephrosis. And a study in Europe actually showed that from 2008 to 2017, that rate has been up 2.6%. From hydronephrosis, if we look now at solitary functioning kidney, so that includes anyone with unilateral agenesis or anyone with a unilateral multicystic dysplastic kidney, because that kidney by definition is non-functioning, we're looking at 0.05% of children, but we are looking at unilateral renal agenesis in 1 in 2,000 births and multicystic dysplastic 1 in 4,300 births. So I want to take a minute to get an understanding of these poorly functioning nephrons, whether it's from preterm delivery and poor postnatal nephrogenesis or from congenital anomalies, because this will connect to how we understand things for current day management. The historical view of dysplastic nephrons was that there was a blockage. There's an obstruction embryonically, and that leads to the dysgenesis, this backup pressure. And if you surgically induce obstruction in a fetal sheep, you can induce dysplasia. However, humans are not exactly sheep, and the same correlate is not seen in humans, meaning that the parenchymal anomalies that we see in the human kidney do not correlate directly with how obstructed a ureter is or how obstructed the collecting system is. So what we have a better understanding now of is that dysplasia, or these inappropriately functioning nephrons, stem from an abnormal interaction between the ureteric bud and the metanephric blastema in embryogenesis. There is something called the ureteral bud theory, and this is an example that shows you how during embryology, those red cells that you see on the bottom right corner of that left-hand picture, that metanephros needs to interact perfectly in the sweet spot with the ureteric bud right there at point B. If you interact there at point B, you get a nice, normally positioned ureter, well tunneled through the bladder wall and without reflux. And then in that middle picture with the red all around the kidney, that is to represent nice, healthy, functioning nephrons all around. That's healthy parenchyma. However, if, for example, the ureteric bud comes off at point A on the left-hand picture, you see that that interaction with the metanephros is imperfect. It's not right at that sweet spot. And then if you go all the way to the right, you see that that ureter then has a ectopic positioning. The ureter is not well tunneled into the bladder wall. You get reflux, and you see the impact on nephron health. So if we were to do biopsies, which we do not, but if we were to do biopsies on everybody with congenital anomalies of the kidney and urinary tract, what we find is persistent, undifferentiated mesenchyme. That's UMC. This is simply to say that this undifferentiated cell pattern normally needs to undergo apoptosis in development. And when it doesn't, that hinders the interaction of what I showed you on the previous slide of that ureteric bud with the metanephros. It gets in the way and it dampens the growth factor signal exchange. So now what are the consequences of having low nephron number? This example is extrapolated from Dr. Brenner, and what we are seeing here is a vicious cycle of progressive functional decline stemming from fewer nephrons having to do more work and work in the setting of hyperfiltration. So at the top, we see genetic mediators, we see birth, environmental mediators, preterm birth, maternal factors, intrauterine medication exposure, leading to different reasons for low nephron number, whether it's just prematurity or having additional congenital anomalies on top of that. That leading to hyperfiltration because those fewer numbers still have to do the same amount of work. That hyperfiltration leads to glomerular hypertension. Those glomeruli get sclerosed and tired. Then you have even fewer nephrons still doing more work. Ultimately, that glomerulosclerosis can be manifested as protein in the urine, specifically albuminuria, and reduced glomerular filtration rate. This is another way of reflecting that. Dr. Cochet is working out of France and exemplifying here the single nephron GFR that needs to increase. Each single nephron needs to do more and more as long as there are fewer and fewer nephrons to do the work. And you see that when you get to lower and lower numbers of nephrons, there's less functional reserve. What you see on the left-hand side is the theoretical view. And unfortunately, what we see on the right-hand side is the clinical manifestation of that. What you see is the serum creatinine starting to go up and albuminuria also starting to present itself. The lowercase mu for microalbuminuria and the uppercase M for macro frank proteinuria. So where does that bring us in the practice of pediatrics? It's our job to assess who is at risk of renal injury. And renal injury has become this umbrella term for any of these three features: elevated blood pressure, protein in the urine, or low estimated glomerular filtration rate. And in scientific publication, number 4 is actually the use of nephroprotective medication as an ACE inhibitor or angiotensin receptor blocker. And what we're going to find as we look along different examples of study populations is that how common this is depends on the study population you examined. And before I get into those details, I do want to share this showing that timing of lower nephron endowment is everything. So we are comparing here the incidence of low GFR hypertension or albuminuria, comparing children who had a congenital anomaly of the urinary tract versus children who lost a kidney, for example, to a Wilms tumor or a neuroblastoma. So they were born with normal nephron number, and then in childhood, they had an acquired solitary kidney. And the lighter bar are the patients with the cancer diagnoses, and the darker bar are the patients with congenital urologic anomalies. And you see significantly higher rates of lower function and hypertension. So this is to keep in mind that the earlier you start in life with fewer nephrons, the greater risk you have long-term of any one of these three manifestations of renal injury. If we look specifically at solitary functioning kidneys as sort of this kind of classic, easy to understand example of lower nephron number, the Kimono study was a retrospective study of 206 patients. 32%, so a third, developed chronic kidney injury at an average of 15 years of follow-up. So this absolutely falls within our wheelhouse and responsibility for monitoring. On the left, you have evidence looking at purely congenital causes of solitary functioning kidney. So there's no mix of congenital and acquired. And just as before, understanding the burden of kidney disease depends on how the scientific question is asked. So on the left-hand side, you see a single center, 128 patients who were screened at birth. That's how they were diagnosed with solitary functioning kidney. And at a median age of 6+ years, 5% had high blood pressure, 3% had proteinuria, and 1.6% had decreased function. However, a systematic review of over 2,500 patients, 43 different cohorts, found the same median age, but much higher percentages of hypertension, proteinuria, and low function. This now is an example from a group in Italy. 56 patients were diagnosed prenatally with solitary functioning kidney, which is more often the case that the diagnosis is made prenatally, and they were followed for 18 years. They were more likely to have evidence of kidney injury if that single kidney also had an additional congenital anomaly of the kidney and urinary tract superimposed on it. For example, reflux. And this is a Spanish study, double the number of patients, but much less follow-up time. And in this study, every patient who developed all three components of renal injury had superimposed congenital anomaly, meaning something like reflux, hydronephrosis, or obstruction. In a slightly larger retrospective study with moderate follow-up here, we again see that superimposed congenital anomaly is a strong predictor of kidney injury, very strong, at hazard ratio of 13. However, we also add the biomarker of neonatal serum creatinine. So it's not about getting tons and tons of labs, but in patients who are already a high-risk setup, if their neonatal serum creatinine, at least past day 3 of life, because we don't want to be measuring mother's serum creatinine, is greater than 0.5, this was a long-term predictor of kidney injury, any one of those 3 features. Additionally, what we see is low birth weight and the absence of compensatory hypertrophy at birth. So just getting an ultrasound and understanding if that solitary kidney has already started to hypertrophy can help us predict who is at greater risk of kidney injury long term. Interestingly here, prematurity was not associated in this study with only 162 patients. Here, we ask ourselves the question, are all solitary functioning kidneys the same? Because we're treating multicystic dysplastic kidneys as solitary kidneys, just as unilateral agenesis, solitary kidneys. That's what they are functionally. But we see that there's actually a very distinct difference in kidney injury outcomes depending on the actual diagnosis here. Unilateral renal agenesis was associated with higher prevalences of injury than multicystic dysplastic. You can see those numbers right there in front of you. And of course, keep in mind, again, this is echoed over and over, a superimposed congenital anomaly of the kidney or urinary tract, like reflux, was an even stronger predictor of renal injury. And this here is a retrospective cohort of 230 patients. And keep in mind that this is all in spite of similar degrees of kidney growth and estimated function between the 2 groups. So they just looked at hypertension and proteinuria, and with similar function and similar kidney size, the rates were different. So this leads us to this image here. Now, this is much later in life. You see that the x-axis here is extending out to 30 years. But we are absolutely in the business of trying to help maintain childhood health for adult life. So what this is showing you on the left-hand side is there's a distinct difference in rates of end-stage kidney disease, whether you have renal agenesis versus multicystic dysplastic kidney. And that is from 2009. A more recent study out of China on the right-hand side, just published last year, shows even worse outcomes for solitary kidney, and this was specifically controlled for preterm delivery. So what about the adult prognosis then? When these children are out of our care, how are we sending them into the world? This is an adult-aged end-stage kidney disease view of a study of Israeli adolescent conscripts from 1967 to 1997. So they were followed for 30 years. And this is accounting for 1.5 million persons. And they found that these conscripts who were deemed healthy to serve, when they had a congenital anomaly of the kidney and urinary tract, they had greater than 5 times the rate of end-stage kidney disease. And this is specifically because at the time they were conscripted, their renal function was reported as normal, no high blood pressure, and no proteinuria. Now, this is a bit older data, but it is of value to connect things here. As practitioners of the field of pediatric nephrology, we're engrossed in the most severe forms of the disease category, like bladder outlet obstruction and posterior urethral valves. And those patients are actually accounted for on the left-hand side of this graph. So what you see is the age that in Germany that they are going into end stage. We are taking care of kids on the left-hand side here. However, even those patients experience a relatively slow decline in function of an average of 2 to 3 milliliters per minute per year. So children who are reaching end stage early in life are there because they had a low starting point. Ultimately, the timing of renal replacement therapy for congenital anomalies, at least in this German study, was at a median age of 31 years. And now that we have a better understanding that aberrant nephrogenesis is not equal across the spectrum, we also need to know, does it predispose to future problems? Does it predispose to tumor formation and cancers? So last year, the same group who studied the Israeli conscripts published their findings related to adult onset urinary tract cancer. And the question posed is whether aberrant nephrogenesis predisposes to tumor formation later in life. And the analysis identified that while the absolute numbers were definitely low, the association of congenital anomalies represented a doubling of the incidence. Once we adjusted for the factors listed, the hazard ratio for men was nearly 2, and for women, 6. And interestingly, there was a very distinct difference in the age at presentation between the sexes. So here, the theoretical mechanism ties back to what we looked at the origins of dysplasia. This persistent, undifferentiated mesenchyme, then with additional somatic mutations. And lastly, we'll cover some management updates. And as all we know, we start with this, first doing no harm. So in preterm infants, whom we know from prenatal screening with congenital anomalies, at the very least, we really need to reduce nephrotoxic medication exposure. As shared in the previous presentation, prevention is better than treatment, and this is what we're addressing here. Now, in 2022, this JAMA paper actually also postulated that for preterm infants specifically, preterm infants with congenital anomalies, that genetics workup should be considered because there was a much higher rate of genetic diagnoses. When it comes to screening for congenital anomalies, and now we're talking about in our offices, in our general practices, there is an absolute shortcoming of the urinalysis as a screening tool. In Japan, they have a very long-term, well-established screening program of urinalyses. Now, in Japan, they're looking for glomerular disease in particular, but they took the evidence they had to look at UAs as a screening tool for congenital anomalies, and they found a detection rate of about 13% in Japanese 3-year-olds. However, the sensitivity is pretty abysmal at only about 30% for children who ultimately had stage 2 chronic kidney disease and 44% for children with stage 3. So we cannot rely on our urinalyses alone. So when I referred to detection of renal injury, specifically in the form of proteinuria, what we're talking about is a random urine sample, definitely not 24-hour, but a random urine sample assessing the protein to creatinine ratio, and with greater detail, the microalbumin to creatinine ratio. When it comes to solitary functioning kidneys, La Scola and colleagues came out in 2022 with a set of guideline recommendations. They did recommend that any fetus with extrarenal malformations, in addition to the solitary functioning kidney, should be offered genetic testing. They recommended that advanced imaging only be used in the event of an uncertain diagnosis. So in the past, we would ask ourselves the question, is it possible that the ultrasound is simply not seeing an ectopic kidney? And really, the literature has not substantiated that. So the ultrasound has been rather good at identifying ectopic kidneys as long as you move your probe. And it is not indicated as a standard, for example, to send kids out for a MAG3 scan to look for hidden functioning kidney tissue. And now, avoiding cystourethrogram is only recommended if your solitary kidney has some kind of abnormal feature on ultrasound. So then the question is, what classifies as an abnormal feature? If you look at the box on the right, we're talking about kidney length, renal parenchyma, pelvic diameter and dilatation, and the general image of what the bladder looks like. So getting back to the idea of recognizing compensatory hypertrophy and kidney length, we want to see that at least before 2 years of life, that solitary kidney is above the 50th percentile. But by the time we get to 2 years of life, true compensatory hypertrophy is defined as greater than the 95th percentile. If there's an abnormal ultrasound, it is recommended that you check a serum creatinine and quantitate the proteinuria at the time that you're making the diagnosis. If, however, the ultrasound findings are otherwise normal, you may just rely on a urinalysis alone. So it's not to say that that we think the urinalysis is better than, for example, what the Japanese study has taught us. Now we're using two tools together. We're using the ultrasound findings and the UA together to give us more reassurance. How about advising families? Sports participation should not be restricted. We do not have evidence that supports, for example, playing any kind of football, American or non, is associated with losing a kidney. However, we do need to share that there are some activities that have a higher risk of trauma, and that includes, for the most part, I kind of reduce it down to horses and wheels. And that's because most of us do not practice where there is a lot of snow. So horseback riding, skating, cycling, and anything on motorized wheels like ATVs. It's recommended that all children be followed into adulthood. And even though we have put a lot of focus on hypertension, recognizing it and managing it, there is actually no routine recommendation yet for ambulatory blood pressure monitoring. Even though ABPM has reached the main guidelines for diagnosis of hypertension in children, it has not made its place yet on more international guidelines. And that's because there has been some conflicting data in the past, not because it is not appreciated that hypertension will lead to a greater rate of kidney loss. We also, in these guidelines, they have expressed a caution with RAS inhibition, and this is specifically to focus that it should be discouraged to use ACE inhibitors or angiotensin receptor blockers, definitely under the first year of life and typically under 2 years of life. And that's because kidney development is so dependent on the RAS system. So for sure in those early 40 days, if any new glomeruli are going to come out after preterm birth, we do not want to be interfering with that mechanism. But we also know that children don't reach adult renal capacity until 2 years of age. So we're very careful with our RAS inhibition. After 2 years of age, you would think we'd like to put it in the water and have everybody on it, because it absolutely is first-line treatment, either for hypertension or proteinuria. So here is an example now recommended for anticipatory guidance and counseling from the primary care prospective provider in children with solitary functioning kidneys. Frequencies for checking blood pressure, proteinuria, renal growth, and function. I do want to finish up with a few slides that address Mullerian anomalies in girls with solitary functioning kidneys and with congenital anomalies of other sorts. And that's because it's been more recently appreciated that there is a rather significant rate of Mullerian anomalies. And you see that, again, there's a discrepancy between solitary kidney, meaning renal agenesis, and multicystic dysplastic kidney, the first two sections at the top of this slide. Overall, in other, there's a very low prevalence, but you see up to 67% of girls with solitary kidney had some form of Mullerian anomaly. On the right, you're seeing all different examples of what those anomalies may be. And you can see the relative rates here. Obstructive anomaly being more concerning because if it's missed and you have a delayed diagnosis of Mullerian anomaly, your patients are at risk of abdominal pelvic pain and dysmenorrhea, pelvic adhesions, endometriosis, and then long-term infertility. So these are things we do want to prepare our adolescent girls for. The prevalence in the general population is clearly much lower than in girls with renal anomalies. And you see the number needed to diagnose is actually rather low. So here, what we're saying is that up to 38% of renal anomalies have a Mullerian anomaly. It is recommended to perform a transabdominal pelvic ultrasound at the time of expected menarche, so 2 to 3 years after telarche. And please keep in mind that a normal menstrual cycle does not rule out an anomaly. So I just want to thank you all very much for this time and this opportunity to share with you updates on what is not the sexiest thing of what we talk about, but definitely has the greatest potential to impact long-term health.
So thank you, Dr. Katsoupas, on updating us on the long-term impact of nephron loss. Are there any questions from the audience? So the question was the long-term management and prognosis of a child with congenital multicystic kidney.
It is definitely
You know.
more optimistic than in renal agenesis, which is why it is important to identify, at least prenatally if you can, or postnatally from the ultrasound, what the original etiology is, because we can be more reassuring to those families from the get-go. So one of those slides compared the rates of hypertension, proteinuria, and decreased kidney function. And those rates are more in the single digits than in the double digits as with agenesis. So the recommendation, there aren't separate recommendations for multicystic dysplastic kidney yet. I can tell you that in practice, Now, this is already at the subspecialty referral level, but in practice, this is what I'm checking, though I'm much more comfortable checking every 1 to 2 years in a multicystic dysplastic than in a patient that has renal agenesis.
Okay. We have another question.
So the studies that you presented and certainly the numbers of um, difficulties with prematurity and the lack of nephrons is very concerning. So for a child who is just premature without necessarily any congenital anomaly on top of that, coupled with the fact that most premature babies are on toxic drugs, how aggressive should we be in our follow-up in terms of renal function of these premature babies as they grow into toddlerhood?
So this is a group that I would argue anyone under the gestational age of 28 weeks should be followed at least annually, and it may need to be more often if you find one of those components of renal injury so that it can be mitigated. There's always what we know the difficulty of measuring blood pressure in children really young and the validity of that. I use it at least as a starting point. I can't say that we're overly aggressive in managing hypertension in children where we don't necessarily trust the blood pressure measurement, but the proteinuria and the kidney function obviously are more reliable. And so the argument here is that the earlier they were born, the greater risk they have. And it is, as we all know, kidney disease is one of the most silent diseases out there. So we have adopted an approach of at least annually in those children, even from the start.
So, are you recommending both blood pressure and urinalysis for the premature infants
We do that.
and kidney
Yes, we
function
do.
as well? So, like a renal. Hello?
Sorry, say that again.
So, are you also recommending a renal as well
You mean
to
kidney
assess kidney
function, like a
function?
renal function
Yes.
panel or an ultrasound?
Renal function test, blood.
Yes, so that we prefer to see one, for example, like that number I quoted, the neonatal value greater than 0.5 as being predictive of long-term kidney injury. So it's helpful to see a neonatal value. And then it can be one, for example, a year later. And then at the 2-year mark is where we draw our strongest conclusions for long-term health, because that's where they should reach adult kidney function and should be in what we all consider the normal range.
Okay. How do you feel? This is my personal question about doing routine urinalysis on healthy children. It used to be a part of the ACIP guidelines, which has fallen out of favor. But from a nephrologist standpoint, how do you feel about doing annual urinalysis on persons who are not diagnosed with any type of renal disease or not known to be at risk?
So this is a really great question, because to understand how it fell out of favor and fell off the guidelines is to understand that the data they extrapolated from to do cost benefit analyses was all on midday urine collections. So children who had their urine collected in the office, for example. And because there is such a high rate of orthostatic proteinuria, the cost benefit did not weigh out. However, I will tell you that in Japan, for example, their urinalysis screening program is on first morning urine samples at home. And if you screen that way, then you can trust your results. You have a much lower rate of false positives, and it can be more meaningful. So I'm not in a position to make an official recommendation about it, but just to share why it fell out of favor, and maybe it was less meaningful when it was performed incorrectly.
Okay, thank you very much. I think we have time for one more question. So the question pretty much was anything that we can do to prevent long-term kidney problems in these premature infants who pretty much almost all have to go on nephrotoxic drugs, some type of ampangent combination and the like.
So when you can advocate against the gent, I encourage you all to do so. But taking a step aside from that, the advice that I give my families routinely so that they can feel empowered to do something as well on their own has to do a lot with what you would probably encourage anyways. And that is significant water drinking above all liquids. There's always the comment I get, but the juices are natural. We make them ourselves at home. And that may be the case, but as we all know, they're still full of tons of sugar. So what I like to explain to the children themselves is you need to clean your kidneys. And the only way to do that is with water. You'd never take a shower with juice, milk, or soda because you wouldn't get clean that way, and neither do your kidneys. And then for parents to understand that when we talk about the burden of hyperfiltration on these nephrons, it is also related to obesity. So starting early, even though in infants and toddlers, we're less likely, even though it's not impossible, but we're much less likely to deal with obesity if we help counsel them very early on to avoid the obesity, because then that becomes a superimposed risk factor for faster progression of chronic kidney disease. The more body there is to clean, the more work there is for those fewer nephrons to do. And then avoiding NSAIDs in particular, because that's the most common nephrotoxin that they are exposed to over the counter.
Awesome. Very good advice. No gent, no Motrin, and drink a lot of water. Okay. Thank you so much, Dr. Katsoupas. Okay, so we'll now move on to our final speaker, who is Dr. Diane Sinqui. And no, you're not seeing double. This is, yes, the sister of our very own Dr. Corinne Sinqui Brown. Okay, so a bit about Dr. Diane Sinqui now. She is currently the director of Pediatric Critical Care Medicine at the University of Medicine and Dentistry of New Jersey, abbreviated UMDNJ. She received her early education at the University of West Indies, where she obtained her MBBS degree, and then went on to do internship and work as a medical officer at the Bustamante Children's Hospital in Jamaica. And then she went on to do her residency and fellowship at UMDNJ in New Jersey. She's held several positions, including intensivist, attending intensivist, assistant professor of pediatrics, director of pediatric critical care residency program at the UMDNJ and also Vanderbilt Hospitals, among other positions. Please help me welcome Dr. Diane Sinqui. And her topic will be discussing death in pediatric critical care. Dr. Sinqui.
Good morning, everyone. Thank you for inviting me to participate in this seminar. So because the time is short, I'm going to speak very quickly and talk about some interesting things that you may or may not know about. These three women that you see on your slide, you may recognize them, and they are particularly important for us in critical care. This person here, Karen Quinlan, was an important person to jumpstart the bioethics discussions and advanced directives. Nancy Cruzan, and all three of them arrested and got resuscitated and went on to a vegetative state. So for Karen Quinlan, her family wanted her to be disconnected from the ventilator. The hospital and the prosecutors actually resisted, and it went up to the Supreme Court, the New Jersey Supreme Court, before the case got settled. When she was removed from the ventilator, she lived for another 9 years. And this just, illustrates that as physicians, we're not always good at prognosis and predicting death or life. Nancy Cruzan, actually, her family, she arrested after a motor vehicle accident. Her family requested her feeding tube to be removed. And again, it took several years before the US Supreme Court actually agreed that competent adults can accept or reject any and all medical care. So her feeding tube was removed and she died several years later, 12 days after it was removed. And the last person here, Terry Shivo, the reason why she's up here, very similar case to Nancy Cruzan, but the interference of her family, her parents, wishes against her husband's wishes, and the interference of the state, and even the US president interfered with getting her feeding tube removed. So I have no disclosures. And what we're going to talk about is something close to my heart. As pediatricians, we actually have the privilege to take care of patients throughout their spectrum of their life, when they're born, through childhood and adolescence, and only occasionally towards the time of death. So my intention is to let you understand just one part of what's going to happen. Here, we're only going to talk about one part of this discussing death. And I'm going to talk about the historical evolution of the declaration of death by neurological criteria, or more commonly known as brain death. I'm going to describe how the physical criteria and testing that may be involved in this determination, so that you can understand the legalities of medical practice and formulate an appropriate management for your patient's conditions. So, like many other things, we have a pretest. And the big question is, are you comfortable? Do you know about brain death, and are you comfortable in discussing it? So if you choose A, then this discussion may be very boring to you. But my intention is for you to not want to choose D, or not understand anything about brain death, so that you can't participate in any discussions with your colleagues or with the families. So we're going to answer this through the keys. Okay? So the answer here is the entire brain function, cortical and brainstem, must be lost for you to be able to declare brain death in the US, which may be different from other countries. So question, do you need ancillary testing to confirm brain death? And of course, the answer is no. So moving on to the case, a 60-year-old girl with asthma comes in with a 1-week history of being ill, and then 1 day of shortness of breath before she collapses at home. She's found unresponsive and not breathing by EMS. CPR is started. They tried to intubate and was unsuccessful, and epinephrine is given before she arrives to the emergency room. And she arrives very quickly. She has a heart rate of 150, no blood pressure, no breathing except for what is given through the ambu bag. She's cyanotic, wheezing, there are no pulses or heart sounds, and she's unresponsive to pain. and her pupils are midpoint and fixed. That's her monitor, and it shows sign of tachycardia, but no pulses, so pulseless electrical activity. And by guidelines, she gets high quality CPR with compressions at 100 to 120 and a compression to ventilation ratio of 30 to 2. She's intubated by anesthesia. The CO2 detector, the EasyCam, went from purple to yellow to indicate that there's tracheal position of the tube. She's given epinephrine, steroids, and continuous albuterol through the ambu bag. 15 minutes later, a pulse is obtained. Her blood pressure is now in the 70s, and she's still unresponsive, still wheezing, and her pupils are fixed and dilated. She's placed on the ventilator, an epinephrine drip is started and titrated to a reasonable rate. Her chest X-ray shows that her lungs are clear, her heart size is normal, and the ET tube is too deep. So it's pulled back. The lab work shows severe acidosis, metabolic and respiratory, a base excess of -10. Her CBC is not really contributory, and her BMP showed, these are the electrolytes, sorry, that her creatinine is elevated at 0.9. Importantly, her toxicology is negative. Her CT scan shows no intracranial hemorrhage, no fractures, no infarction, normal ventricles. And so she gets admitted to the ICU. So 24 hours later, as you may imagine, she's now very hypertensive. Her CVP is 10 to indicate that her intravascular volume is okay, and she's wheezing, but now has better air entry. There are no vasopressors now on board, and her neurological examination, she has lost all her reflexes, and she has fixed midpoint pupils, except that her feet move when her soles are stroked. So the CT scan has been repeated, and now we have lost the basal cisterns, and there is global cerebral edema. So the loss of the cisterns indicate tonsillar herniation. So now the question is my patient dead? A brain flow study was done, and it shows no intracranial flow. So there is perfusion to the scalp, to the face, to the trunk, but nothing inside the skull. So in the past, it was a lot easier to figure out when people were dead. So if you stop moving, you stop breathing, you turn blue and your heart stopped, then everybody agreed that you were dead. But in the 50s, during the polio epidemic, ventilators were now available outside of the operating room, and it allowed patients who were in irreversible comas to survive. So if you believe that medical care is expensive, ICU care is even more expensive, and there are insufficient beds to allow for admission to everybody, then maybe the society actually needs to be able to triage and allocate scarce resources. So, and then the final thing is that organ transplantation now started to be available both safely by surgery and by the medications to prevent rejection. So for these reasons, the neurologists at Mass General actually suggested that we can predict severe brain injury just by a neurological exam. And in 1963, they proposed that we could actually certify that patients could be dead even if they had a beating heart, if they met the criteria for severe brain damage. And so the criteria were coma, fixed dilated pupils, absent eye reflexes, flaccid paralysis, apnea, and an isoelectric, a flat EEG monitored for at least 30 minutes. So this prediction was that if things happened naturally, then if patients had remained in a coma, they would stop breathing and progress to death. So the paper was published in JAMA in 1968, and a few years later, many of the states in the US actually adopted it as a part of the Declaration of Death. So Congress in 1981 actually, because we have to ensure that the entire union actually proceeds similarly, that this new definition of death could be a part of our law. So a person can be dead if their heart and breathing stopped, or if they lost the entire function of their entire brain. So you can imagine that this new definition may have caused the public some consternation. And Robin Cook, who was actually a resident before he started being a novelist, wrote this novel about coma that got produced as a movie. And this was a hospital in Boston that patients came in who were young and healthy and became vegetative afterwards for no apparently good reason. So this intern, the surgical intern, looked into it and found out that the hospital, the chief medical officer, and the surgeons were in collusion to make these patients a repository for organs that were sold on the black market. So considering that that was a movie, you can imagine that the public was also maybe a little bit suspicious about what was happening. And people would be concerned that the person, their family, was in a coma that could get better if the physicians actually allowed it. But probably more importantly is that this attitude that the doctors may be intentionally killing people to allow organs to be obtained. And this talk is to help you to prevent this from being the conversation between you and your patients' families. So the first question is, when should brain death be considered? And there needs to be a catastrophic event that occurred that could explain why the brain lost entire function. And New Jersey is a little bit peculiar. We're the only state in the US that actually has a religious exemption. So if we had evidence that the person or the family does not believe in brain death, then we have to wait for the usual cardiorespiratory demise to be able to declare the person dead. So this is in our legislation that was started in 91 and several updates later. And this is the current declaration. So that was actually signed in 2017. So it defines who are the people who are allowed to do the examination and the certification. So for patients who are less than 1, the physicians have to have pediatric training. So the pediatric intensivist, neurologist, or neurosurgeon, and if it's a neonate, then the neonatologist. People who are over 1 can have several doctors do it as long as they're appropriately trained and credentialed by the hospital. And importantly, anybody who is involved in organ transplantation may not be involved in the declaration of death because of conflicts of interest. So these are the criteria that must be met. There has to be irreversible deep coma, the absence of all neurological function, both cortical and brainstem, and the presence of apnea. And if the criteria cannot be met, cannot be certified, then additional confirmatory tests may be needed. So how do we define irreversible coma? So remember I told you, the cause has to be sufficient to account for loss of all function. Coma has to be permanent, untreatable, irreversible. So anything that could look like death, which would be things like severe hypothermia, shock, severe metabolic electrolyte abnormalities, toxins and depressants and paralytic agents, have to be identified and treated appropriately. So the higher brain function awareness has to be absent, and anything that could be reflexive that comes from the cortex, such as seizures or from the brainstem, breathing and posturing, has to be absent. And these are the brainstem reflexes that we all know: the fixed dilated pupils, corneals, cough, gag, doll's eyes, and cold caloric testing. So the pupillary response, I won't describe because everybody understands that. The corneal reflex, and this is the doll's eye maneuver. So if their patient has evidence of a cervical spine injury, then you may not want to do this test in somebody who you're not absolutely certain that he could be dead. And the cold calorics, we choose cold water because it elicits a more vigorous nystagmus than warm water. The apnea test and the description of the apnea test is available in a lot of the literature, and it's also iterated in the New Jersey law. So for the apnea test to be done, the patient is pre-oxygenated to allow for a longer time off the ventilator. He's disconnected, oxygen is insufflated through the endotracheal tube, and a blood gas done before and after the disconnection from the ventilator. And so we look to see if the patient breathes. Any of these 3 things should terminate the test. If the patient breathes, then the test is negative. If the patient starts to lose his blood pressure or becomes hypoxic, then we cannot proceed because this will ultimately end in death. So remember 3 steps: the unconditional certainty that the brain injury is irreversible and fatal, and then excluding what we talked about: sedatives and muscle relaxants and toxins and severe hypothermia. So what if these 2 requirements could not be certainly excluded? So in that case, then we would have to do a confirming test. So when would the brainstem reflexes be untestable? If the patient has severe facial injuries, then all of these reflexes are on the patient's face. So if you can't see the patient's face, then you can't actually test the reflexes. So my patient that I described before had some movement of the feet. So if there is indication that these are spinal reflexes, then we're okay. But if there are some other complex movements, then sometimes we don't know what is going on. So those would be the reasons to do a confirming test. And in the New Jersey legislature, they actually identified what tests may be done. We have removed the EEG from testing because it only tests the cortex and not the brainstem. So it probably isn't a good test for brain death. So remember, if the brainstem reflexes are not testable, toxins that may not be identified in the urine toxicology test, but we have, reason to believe that they're on board, then if they're not measurable, then we should do a confirming test. So a gold standard, the cerebral angiography, probably not done very often because it needs a radiologist to actually do this. So here we see intracranial flow and then absent here. So the alternative that we have now depending on for so many years is CT angiogram and the MRI angiogram. However, in the current Academy of Neurology, they decline using this test because it has not been validated. But look at how superb the anatomy description is here. Anyway, so here is a nuclear scan that we see that there is perfusion to the face, to the scalp. This patient had a craniectomy, and there is nothing in the patient's skull. So this empty skull is what shows us that there is no cerebral blood flow. And if there is no cerebral blood flow, then there is no perfusion to the brain. If you have the expertise at your hospital, the transcranial Doppler is also a pretty good test. So what about us in pediatrics? Well, the important part here is that if the infant is premature, then their brainstem reflexes are not good enough to be actually tested and validated that if it's absent, that it's because they're brain dead rather than they're just premature. So the AAP has made a pretty valid and definite statement that the premature infants cannot be declared dead by criteria if they're less than 38 weeks. So the observation period, so remember, we don't have to have a confirming test. So if we can ensure and certify that coma has persisted, then we can actually declare that the patient has no function. New Jersey has chosen these times, and the patients who are under one, according to the AAP, and less than 6 hours. However, you have to ensure that your observation period for your country is actually defined in your legislation. So for New Jersey, 6 hours for everybody who is greater than 1, 24 hours, and 48 hours for the patients who are neonates. And if we can't use the timing, then we have to do a confirming test. So there the countries around the world have some variations in what is necessary as testing and whether or not there is a whole brain death or just a brainstem death for certification. So remember, brain death, so no cortical responses, so no awareness, no brainstem reflexes, and an apnea test that showed no breathing when the CO2 is greater than 60. So after brain death is determined, your actions now are to pronounce the person dead. And the time of death is when brain death was certified. The families should be in direct communication with you throughout the time since the patient was admitted, through the testing, and at the end of the test, whether or not the person has met the criteria for brain death or not. So if they did, then you have to tell them what it means to be dead, that brain death means legal death, and provide the usual emotional support and allow them to grieve. If there is any indication that there is child abuse or neglect or any possibility of homicide, then the police and the medical examiner and Child Protective Services are also notified. And here in the US, there is a federal mandate that the organ sharing network also be notified before the declaration of death so that they may be involved in the discussions with the family if they want to be organ donors. So if the person is going to be an organ donor, then they're maintained supported in the ICU until they go to the operating room where the organs are removed. And if they're not an organ donor, then the mechanical support is discontinued after the family has been allowed to visit with the patient. So now we go to a couple cases to figure out, did you understand and are you able to use the information that I just gave you to take care of a patient? So a 15-year-old patient came in after a very short history of headache and vomiting. He collapsed at home, EMS was called, and found that he was unresponsive with fixed dilated pupils and a respiratory rate of 6. So he got intubated, came to the emergency room where there was no responsive pain, fixed dilated pupils, absent reflexes, and now there was apnea. The CT scan showed acute hydrocephalus and cerebral edema, and his lab work was normal. And the toxicology screen was also negative. So neurosurgery gets called. The opening pressure for an external ventricular drain was greater than 50, when normal is between 10 and 20. His CSF showed a white count of 50, red cells of over 900, and lactic acid of 10. So IV antibiotics, ceftriaxone was chosen, acyclovir, norepinephrine was given to support his blood pressure, and then vasopressin was later started when the patient had polyuria from diabetes insipidus. So after he gets stabilized, he's monitored for another 12 hours, and there is no change in the neurological examination. So what's the next step? So I'm sure you figured it out, the apnea test, and if the CO2 is greater than 60 and he doesn't breathe, then he's declared dead. So maybe a simpler case now, a 5-year-old drowns and gets resuscitated, comes to the emergency room, eventually goes to the ICU, and 10 days later, she has no cough, no gag, no breathing, fixed dilated pupils, and the rest of the brainstem reflexes are absent. Her examination is exactly the same in the last 2 days. So an apnea test is done, and 2 minutes into the apnea test, she takes one really small breath. So, which of the following can you reasonably do for this particular patient at this time? So this is the only one. So let's go back to figure out why that was the answer. So remember, she met criteria here for brain death. So this is the clinical criteria of what we look at. And then when the apnea test is done, she had a breath. And whether it's a small breath or a big breath or continuous breathing, it doesn't matter. So this indicates that she still has brainstem activity. So if she has brainstem activity, then we can't declare her dead. If she has brainstem activity, then we can't order a confirming test because she didn't meet criteria for brain death. And since we can't euthanize patients, then B, we can't do. So C, if the medical team and her family think that therefore the prognosis for anoxic recovery from anoxic brain injury is extremely poor, if everybody agrees, then she can be extubated, and just like Karen Quinlan, she may or may not be able to breathe on her own for a long time, but this will allow a natural course for the patient. And if she dies, that would be appropriate to end her pain and suffering, if that's what the family wishes. If there is any indication that there are ulterior motives, then you may have to make this determination with the legal authorities at your hospital. But of the choices that are here, this is the only one that is within reason. So remember, the final word is, what are the criteria for brain death? Oops, sorry. So 3 criteria after a catastrophic injury that would account for the absence of the entire brain function loss: permanent coma, absent brainstem reflexes, and apnea. These are the references. So these are the newest guidelines from the American Academy of Neurology, and that has been endorsed by Pediatrics. So there are a few things that have been updated in the previous discussions, but what I gave you is what is current. So this is the important part, the important end to my talk. These are the opportunities for your education, discussion, and self-growth, to understand death and dying, to talk about palliative care after giving your patients life-limiting diagnoses, to talk about bioethics and advanced directives, and organ and tissue donation after death. Thank you. Any questions?
Dr. Singri for a very informative talk. We'll now entertain any questions, either from the audience here or joining us virtually. Okay, so we have one question.
I did have a question I was curious about when it came to organ donation and those children who may be like under 18. What are the steps for that? Like, are there any specific things that you have to go through, or is it just not done in certain institutions?
Well, so I can't talk about the Bahamas and organ and tissue donation, but there should be a process. And remember, tissue can get donated after cardiac death, not just after brain death. But for you to be able to donate organs. So the organs, heart, lungs, liver, kidneys, pancreas, there are a lot of organs that can be donated. The person has to have a beating heart before the organs are removed for it to be a tenable way to donate organs. So this can occur after, if your patient actually wanted to withdraw, so cardiac death, but in the operating room, and the organ removal can occur at that time. So depending on your surgeons and transplantation being available, then that would be the process. So your hospital would have to have the surgeons available for organ donation to occur. Did I answer your question, or was it a different type of question?
That's fine. Thank you. Are there any other questions? Okay. And okay, so we have a comment in the chat saying very powerful and informative presentation. Well, if there are no other questions, we would like to thank Dr. Sinqui and all of our speakers, Dr. Jones and Dr. Katsipis, for taking their time out of their busy schedule to participate in our second annual Pediatric Weeks lecture series. And I would like to say a good morning and have a great day to everybody who is tuned in as well. Thank you very much.
Thank you.
Thank you. Have a wonderful day.
Thank you.